Welcome back, everybody. I hope you've enjoyed the event so far. Hope you were able to get a little break from screen time over lunchtime, stretch some legs. We're staying in the main room for this next session. So next up on our agenda, we're really pleased to have Gayle Munro with us. Gayle is the director of the Centre for Children and Families at NatCen, or the National Centre for Social Research. And you heard Phil mention earlier that there's a national evaluation ongoing. So Gayle's team leads a research consortium undertaking the national evaluation of A Better Start. And the aim there is to demonstrate overall impact of the programme and the experiences of all of those people who've taken part. Gayle's going to tell you a bit more about the evaluation and some of the emerging findings. And then we'll have some time at the end for any questions. So if you think of any questions while Gayle's talking, pop them into the chat and I'll keep an eye and I'll come back on afterwards to pick up on those. So over to Gayle and thank you.
Thanks very much, Claire. Just bear with me a minute while I share my screen. Hopefully this is going to work okay. So it's great to be here today and have the opportunity to present some of the findings in progress from the national evaluation. So I'm here representing the team today. We are now 3 years into our 5-year evaluation. So we started work in April 2021 and our evaluation will run until March 2026. So I'm going to be talking today about some of the kind of high level findings of the evaluation work so far. And then at the end, I'll also provide some links to some of our recent outputs if you'd like to explore the findings in more detail yourselves. So just as a reminder, I know I have spoken about this before at various events, but our approach to the evaluation draws on contribution analysis. That's our theoretical framework, which we are kind of looking at the impact of A Better Start against. So we're looking at the impact that ABS has had on the lives of families, on childhood development outcomes, on systems change, and on the public purse. So the evaluation is aiming to build a mosaic of evidence from 4 objectives. Objective 1 is using health and education data to map change in the childhood development outcomes of diet and nutrition, social and emotional development, and communication and language. And it's doing this by comparing data from families living in A Better Start wards with families living in areas not in receipt of A Better Start funding. Objective 2 is taking more of a qualitative approach to looking at how A Better Start as a programme is implemented in practice. So we're doing this through interviews with staff at A Better Start partnership areas, and then also with staff in similar roles in areas which don't receive Better Start funding. Objective 3 is working with a cohort of 25 families from across the 5 partnership areas over time to explore and document how Better Start is impacting upon their lives. And then objective 4 is using cost-consequence analysis to document the impact which Better Start is having on public spending. So whilst I'm here representing the team today, we are a wider consortium, as Claire mentioned, of organisations working on the national evaluation. So NatCen are leading objectives 1 and 2. The University of Sussex is leading objective 3, which is the longitudinal qualitative work with families, and RSM are leading objective 4, the cost consequence analysis. And then we have 2 panels which inform our work. So Research and Practice facilitate our practitioner panel, and NCB facilitate our parent panel. And then as consortium partners, we also act as critical friends to each other. So our evaluation is informed by a theory of change, and I appreciate there's quite a lot of information on that slide. You can see here the different strands of evidence that we're collecting against each of the different parts of the theory of change. The little coloured key shows the kind of evidence that we're collecting against each section. This is in the evaluation protocol, and there's a link to that at the end. So if anybody wants to take a closer look, there's a link at the end. So I spoke at this event last year, and I gave an update then on when we were at the time, where we were at the time with the national evaluation. So I'm just going to give an update on what's changed since then against each of the objectives. So on objective 1 this year, we have been working with the partnership areas to establish parental consents for linking data, families data with health data from NHS Digital and the Department for Education's National Pupil Database. So we had already agreed a different approach in Lambeth, but you can see here that we have consenting beneficiaries from 2 areas are going to be a bit small to have a sufficiently powered analysis for statistical significance between a Better Start partnership areas and non-Better Start areas. So we are currently rethinking our analysis plans to focus on a whole ward approach instead. Access to NHS England and National Pupil Database data isn't straightforward, and there's been a bit of a delay in accessing the health data in particular, but we are hoping to be in a position to start analysis of the education data from September. We've had an update from DfE on that last week. And then we're considering a combination of whole ward data analysis using those 2 administrative data sets, and then pseudonymized beneficiary data analysis from data that the partnerships are going to share with us directly. So each of the objectives has a different time scale in terms of where we are with data collection and analysis and reporting. And we were aware from the start that objective 1 was going to be quite a lengthy process, just because of the need to gain consent from families and make sure that everything's kind of set up with data sharing agreements properly across each of the 5 partnership areas. So moving on to objective 2. Over the past year, we've carried out another 2 waves of qualitative fieldwork for this objective. That's been a total of 39 interviews with staff working at Better Start partnerships, either within the core Better Start teams or for delivery partners. And those 39 interviews have been split across the 5 partnership areas. So there have been some common contextual challenges across the 5 areas, regardless of which child level outcome area we're looking at, mainly related to the ongoing effects of the cost of living crisis, where families' needs and trying to sort of meet their families' basic needs is having an impact on parental engagement with services. So families who are worried about meeting basic needs around access to food and somewhere to live are less likely to have headspace to give to attending, for example, a pregnancy support group or an early intervention speech and language drop-in. Then the impact of stigma perceived by parents, especially in relation to targeted social and emotional related support, also came across through our interviews. And some parents are reporting to services that they are reluctant to attend a support programme because of worry about being thought of as a bad parent, especially in the social and emotional development domain. So in terms of what's worked well in common across the 5 partnership areas, what's coming through very clearly are positive working relationships between Better Start delivery partners and the core Better Start teams, and then joined up working between different organisations and teams working around the family to deliver holistic approaches. So this speaks very much to the theme of today's conference and what we've already heard this morning. So, for example, our interviewees talked about working collaboratively through triage panels to develop support plans and also to coordinate care with non-Better Start service providers. Then in terms of the 3 child level development outcomes, what's working well, if we look first at diet and nutrition, early intervention is one area which our interviewees reported working well, and in particular the presence of support staff from an ABS infant feeding service on maternity wards is one example. The role of a Better Start in establishing pathways of support through the infant feeding processes, from choices around newborn feeding through to the introduction of solid foods, and then later choices around healthy eating, was particularly welcomed. And then since the last wave of interviews that we did, Some diet and nutrition services have also expanded their reach geographically, partly in response to the cost of living crisis and partly to cover areas where there had previously been low uptake from families. In terms of communication and language, improved screening processes was a definite highlight, especially the traffic light system introduced by the Welcome screening tool. That's resulted in an increase in referrals for the youngest children. And then the impact of early support has meant a reduction in children being referred for more specialist clinical support. Peer support roles for speech and language has meant that the speech, language and communication triage panel has been able to make more informed decisions about a family's support needs because of the level of intelligence that the peer support worker has been able to provide. And then regarding social and emotional development, again, in line with the theme of today's conference, working together in partnership was seen as a particular success, and the use of gentle, jargon-free and non-judgmental language in working with families. So in terms of some of the challenges faced by services, in diet and nutrition, some services have found recruitment tricky, which means that their supply can't always meet the demands with an impact on waiting lists. And then some catering agencies don't always provide food which can respond to all dietary preferences. And then regarding communication and language, COVID has continued to have an impact with long waiting lists for support in some areas and also a high turnover of staff has meant that new recruits are always in need of training, which then takes staff away from the kind of more sort of day-to-day elements of their jobs. And sometimes it's not always possible to release staff for training. And I think it would be fair to say that the social and emotional development that childhood development domain suffers a little bit from a kind of identity crisis in comparison with the other two child level development areas. It can carry more of a perceived stigma for some families who may be comfortable talking about their child's speech and language support needs, but they are less keen to acknowledge that they may need some support with general parenting. And the fact that it's a less well-defined area of support also means that some parents are less aware of the nature of the support on offer, and services have to work harder to encourage families to engage in the first place. And the complexity of the service offer and family support needs can mean that staff recruitment is difficult, and some support staff are having to travel long distances and almost piggyback off other support offers in terms of location and then a dedicated space for a service to take place in. So the fourth outcome domain of systems change, we've always found that more challenging, to be honest, to collect qualitative data on and to do analysis and report on. So our interviewees don't always have a common understanding of what is meant by systems change. The narrative around it can be quite vague. It can be quite difficult to pin down in a meaningful way. So when we have talked to our participants, working together in partnership is seen as key in being able to achieve lasting and meaningful change in families' lives. Leadership within the core ABS teams has also been highlighted as really positive, and in particular, its intentional lack of a top-down leadership approach is allowing services to be innovative and to be creative. So this has meant that services can be tailored more effectively to a family's needs and with an offer of multidisciplinary support. There were a few challenges mentioned around staff turnover, and some non-Better Start services are perceiving a Better Start to be transient, which means that there's some reluctance to invest in working together. And then quite a few of our interviewees expressed concerns about staff retention and the possibility of that likely to be a challenge as the Better Start programme moves towards its conclusion. Some of our interviewees raised concerns that some of the child level outcome areas are more likely to attract focus and therefore funding in the future because of a perceived relationship with school readiness and then ultimately academic attainment. And some of the more niche Better Start services, although they're effective, are perceived to be expensive and resource intensive and may therefore be less likely to be recommissioned in the future. So moving on to objective 3 and the longitudinal work with families. University of Sussex initially recruited 25 families from across the 5 Better Start partnership areas, and they recruited a sample of families to represent the diversity of families using Better Start services, both in terms of family characteristics and the use of services. So we have families with a mixture of children aged under 12 months and then 13 to 36 months. Family size ranges from 1 to 7 children. We have single parent households, 2-parent and multi-generational households, and families of different ethnicities. The more recent interviews by the University of Sussex team with families have highlighted how some families are continuing to live in complex and sometimes challenging circumstances. Childcare patterns change, obviously, as the children grow older, and their follow-up waves of interviews have documented how relationship breakdown has been a feature in 4 households, with 2 other households reporting parental relationship difficulties and pressures. The cost of living is continuing to bite, with interviewees in 9 families reporting having to make significant cuts in family budgets in response to rising food and energy bills. A Better Start has helped some families with food vouchers and putting them in touch with charities for support with material goods. One family spoke about how the increase in demand for the local food bank has had an impact on the availability of food and on the amount of time needed to queue at food banks. And another family has described how eligibility for food support locally has had to change in response to increase in demand. So within such a context, families describe the role that Better Start has in providing free or affordable activities, which is of benefit to parents and children. So families describe the feelings of burnout that they've experienced because of the extra pressure which the cost of living has placed on their mental health and also on their relationship. One mother described the support provided by a Better Start as a form of sanctuary, somewhere to go for comfort and reassurance, and has described it as a second home. The flexibility of Better Start services was particularly welcomed, and especially the ways in which services can respond to families' changing needs over time, particularly in families where one but not all of the children have special educational needs, or in families which have experienced changing relationship difficulties. Facilitated access to more specialist services was also welcomed, and A Better Start was seen as a safe and non-judgmental space for parents to have support with their own mental health challenges, enabling them to then better meet their children's needs. And again, some families did express concern about what would happen once Better Start funding came to an end, with a perception that in some areas things are already starting to wind down towards their conclusion. So in terms of childhood development outcomes, parents consistently express that Better Start has improved their knowledge of child development and has increased their confidence. So one mother, for example, talked about how Better Start has encouraged her to be confident that she doesn't need to be a perfect parent and to focus on what she's able to do realistically for her children. Diet and nutrition was one childhood outcome area where parents reported particular levels of tension and challenge, particularly the pressure to make healthy food choices against the backdrop of rising costs of living. And then moving to objective 4, this is run by RSM. So here we've got the program delivery costs, the data that we have to date. And you can see here the Better Start grant spend by partnerships. That's split into the 5 different partnership areas. There are central program costs. So, for example, time and expense for the staff at the fund who are responsible for management and oversight of the program. That totals around 2% of Better Start total spend up until 2023 to 24. The grant spend by partnership totals around 79% of project spend. And then we've got support and delivery activity costs. So examples for that include development grants paid to the initial 15 sites, that the list of sites at the beginning, to develop their Better Start proposals. And that also includes things like contracts for communication campaigns. That's around 8% of the total. And then leverage funding. So that includes grants, funding and donations that have been allocated to support Better Start activity, as well as non-monetary commitments from partners, such as provision of services or facilities to Better Start beneficiaries on a free or reduced fee basis. That comes to around 12%. And then if we look at the partnership areas individually, so for Blackpool, the largest proportion of Blackpool's project spend has been allocated to achieving systems change. And at least some of the spend from 26 different projects was mapped to this outcome. So examples include family hubs funding, community connector teams, the early years volunteering and representative voice, capital parks development and workforce development. And then looking at Bradford, all of this information is available in the annual report, by the way, which I'm going to link to at the end, because I appreciate it's quite a lot of information to take in. So moving to Bradford, the largest proportion of Bradford's project spend was allocated to perinatal maternal mental health, depression and anxiety. And then at least some of the spend from 9 projects was mapped to this outcome. So examples include family action, perinatal support, baby steps, and Little Minds Matter. And then the second largest proportion of Bradford's project spend was allocated to communication, and that includes 7 projects, the Incredible Years Parenting Programme, and Little Minds Matter. So Lambeth allocated most of their project spend to other outcomes. This included social capital at around 10% of the total allocated spend, breastfeeding initiation at around 3%, and then the remaining 12.7 million of the total project spend was allocated to other outcomes, allocated to 6 different parent or child level outcomes, including improved parental mental health and well-being, secure attachment to a trusted caregiver, improved maternal physical health and nutrition, and more families have strong support networks. Children have a BMI that's neither high or low, and more survivors of domestic abuse are accessing appropriate specialist support. And then the second largest proportion of Lambeth's project spend was allocated to child development at age 2 to 2.5. Okay, and then moving to Nottingham. So the largest proportion of Nottingham's project spend was allocated to achieving systems change. 13 projects were allocated spend to this outcome. So for example, specialist delivery and supervision teams, program evaluation and learning, community voice, community connections, and program communications and marketing. And then the second largest proportion of Nottingham's project spend was allocated to school readiness. And that included 3 projects: the Family Mentoring Project, Book Gifting, and the Innovation Fund. And then for Southend, the largest proportion of Southend's project spend was allocated to communication. That included 14 projects. For example, Let's Talk, Father's Reading Every Day, and Baby and Us and Being a Parent. And then a substantial proportion of Southend's project spend was also allocated to perinatal maternal mental health, depression and anxiety, and that included 13 projects. And those examples included a family nurse partnership, perinatal mental health, and one-to-one breastfeeding. So we can see from these slides that there's considerable variation in the profile of spend across the 5 partnerships in terms of the outcomes that they directed the most money towards. But some of it is also due to sort of perceptions, really, and how each partnership area labels, you know, which domain the funding goes towards. So I appreciate that's probably been quite a lot of information, and we have a number of outputs that we've published since the last time we presented. So if you are interested in following up in any more detail on anything that I've talked about today, we have got a website which hosts all of our outputs in progress. So the evaluation protocol is useful for anybody who's interested in our overall approach to the evaluation and our methods, including contribution analysis. And then our recently published outputs include our second annual report, our themed report for this past year, which has been on parental engagement, and the findings from our first local evidence synthesis, which reviews the evidence from each of the local evaluation partners. Thank you very much, and happy to answer any questions either now, or if I don't know the answer, then I might need to follow up.
Thanks so much, Gayle. That was really useful, really interesting. If anybody has any questions, then please pop them in the chat. And just while we wait for that, a question from me. Has there been anything totally unexpected that's come out of your evaluation so far in the findings?
So I think what comes across really clearly is the passion that everybody has for the program. That's come across right from the very beginning. The staff that we spoke to obviously care really, really deeply about the families that they support. The parents that we've worked with on the parent panel, and also the parents that we've interviewed, the level of kind of commitment and trust that they have for the Better Start work and the support that they received is just quite overwhelming. So it's not that we didn't necessarily expect it, but when we sort of look at some of our other evaluation work, which tends to be a little bit drier, I suppose, the amount of passion and commitment for the program is quite intense.
Thank you. Okay, a lovely question in the chat here from Fiona saying it's lovely to hear the voice of the parents within this. Does the evaluation seek to include the voice of the child? And I know there's lots of lovely work going on as part of the research activities. Tell us a bit more.
Yes, so that was a real discussion that we had right back at the proposal stage. Actually, we were sort of looking at whether we were going to be talking to parents, setting up a parent panel, the age of the children, how we could meaningfully include the voices of children when as young as they are. So there was a lot of back and forth, and I think it's fair to say that we didn't all necessarily agree on the approach. But where we ended up is that the parents, that the families that the University of Sussex are working with, those interviews, most of them are held in the home. Some of them are held in sort of local parks, local community areas, and almost all of them include child input. So the children may or may not be present with the parent as the interview is taking place. The child is given a sort of bag of different things to kind of play with: crayons, paper, camera to take photographs of things that they are playing with. And the team at Sussex very much involves the children, all different ages of children, in that interview process. So it's very much a kind of holistic family approach to gathering the data. So it's not just like a dry researcher and interviewee one-to-one sort of approach with a very set topic guide and a very kind of structured set of questions. It's very kind of hands-on, and I think the team at Sussex are really getting to know the families, and as they, because it's a longitudinal approach, as they're speaking to the children multiple times, they are building trust up over time.
Thank you. Research, of course, could never be dry, and so many exciting things happening there in terms of methodology. We had another question in the chat. How much quantitative outcome data have you gathered?
So that's definitely been one of our challenge. Well, it's not a challenge to gather the data. It's been a challenge to gain appropriate consent to gather the data to start with before we even got to the data gathering process. So we think we have established permission with DfE to access education data. So that's going to be happening over the summer. And then the health data we are hoping will follow shortly on the heels of that in the autumn, but that's an ongoing conversation that we're having with NHS England at the moment. And then the Objective One team are working really closely with the 5 partnership areas to gather as much quantitative data as we're pseudonymized quantitative data as we're able to. So we're going to have a kind of combined approach where we will be able to link data, health and education data, with family data for those beneficiaries that have given us consent. And then we will have a set of data which is pseudonymized, so we won't be able to do any linkage there, but it will be at site level. So it's going to be a bit of a combination. But I think one of our points of learning has been that the length of time that this takes is really significant and can't be underestimated. And one of our outputs at the end will be to write up some of the learnings that we've had around how to do evaluations of this scale with programs this complex and this big. So we'll be reflecting all of that in the final outputs.
Great, thank you. There's quite a few comments in the chat just asking for links and things. So just to confirm, we'll share everything that we have available after the event so that people can log in and have a look at all of those. Gayle, just a last kind of question to wind up then. So you have touched on this already, but it's quite a big consortium. There's lots of partners involved. There's lots of different strands of work. What have you found to be the big challenges for the evaluation? And of course, how have you addressed those?
So I think the quant data has definitely been a challenge, and I think we were perhaps a little bit naive right at the beginning. I had assumed that it would just be a much faster process than it has been. So if we ever did something like this again of this scale, we would definitely take that into account. I think managing people's expectations around that has also been a bit tricky. Um, Ideally, we this is a contribution analysis approach, so it's a mosaic of evidence. One of our challenges at the end is going to be knitting it all together and trying to make the 4 objectives make a kind of coherent story, I guess, the contribution story of a better start. I can see there's a question about accessible ways to access in the research. So we have published podcasts and webinars summarizing our findings to date. So it's not all written 100-page PDFs. There are other outputs as well, and we will be making sure that we do that at the end also. And again, it's kind of knitting together the 4 objectives. We talk quite a lot about the mosaic of evidence, but actually trying to make it work in practice is quite challenging.
Okay, I think that will do us for now. Thank you so much, Gayle. We really appreciate you coming and for sharing that. And again, we will share any of those links so that people can read more about it.